few minutes after 4 Eastern, so I think we'll go ahead and get started. As I said, remind everyone to please mute. If you have a question or a comment, please know that you can submit that via the question and answer feature on your Zoom toolbar, and we'll do our best to address all of those at the end of our discussion, at the end of Dr. Opipari's presentation today. Thank you for joining us. This is our first Career Physician Insight presentation. My name is Sarah Godley. I am a Vice President of Advisory Services at Career Physician. I'm pleased to be joined today by Dr. Bruder Stapleton. He is the chair of our Child Health Advisory Council, as well as a professor of pediatrics and chair emeritus at the University of Washington. Also pleased to be joined by Dr. Valerie Opipari, who will be presenting the lion's share of the content this afternoon. Valerie is a professor and chair emerita of pediatrics at the University of Michigan. Wesley Milliken, who is our CEO and physician talent officer, unfortunately has a positive COVID diagnosis in the last about 10 days. And just wanted me to pass along a personal thank you for all of you for taking time out of your day to be with us today and to join this conversation. The goal of Career Physician Insight is to bring expertise from Career Physician and the Independent Child Health Advisory Council to pediatric leaders across the country. Since this is our first session, we thought it would be important to provide a brief overview of Career Physician, and the evolution of our Child Health Advisory Council. Then we're going to turn it over to Dr. Stapleton, who's going to talk specifically about a pilot project that the Child Health Advisory Council was engaged in with the University of Oklahoma. And then we are going to turn it over to Dr. Opipari, who will focus on leadership strategies in challenging financial times. Today's Career Physician Insight is really the culmination of 20 years of commitment to academic pediatrics. Career Physician is an executive physician search and leadership development company with more than 20 years of academic pediatric experience. As a firm, we saw an opportunity to create a hub and spoke model that places academic pediatric leaders and the organizations they serve at the center of this model. We are unique in that we offer a full suite of services, from department and institutional review through search strategy and execution, executive coaching, succession planning and talent alignment, as well as resident and fellow education, all around placing the academic leader and the organizations they serve at the center of this model. Our goal is to position leaders and the organizations they serve to be successful by building competencies in 9 centers of excellence that you see here in the middle of this circle. After working together for many years, Wesley, who I mentioned as their CEO, and Dr. Bruder Stapleton saw an opportunity to create the gold standard in leadership development. They wondered how you could empower leaders and the organizations they work with by harnessing the experience of successful pediatric leaders and infusing that into the offerings of Career Physician. And that is how the concept of our Child Health Advisory Council was conceived. As you can see from this hub and spoke, we are able to bring the continuity and experience and expertise of the Independent Child Health Advisory Council and infuse it into the work and the process of Career Physician as it meets the needs of the clients and the organizations we work with. Dr. Stapleton is going to take us through his thinking as he and Wesley developed this concept and provide a little bit more context on the evolution.
Well, welcome everyone. I'm so sorry that Wesley isn't able to join us, but appreciate you all joining us today. This first slide really is intended to show the kind of incubation of an idea. As a chair, and I'm sure as you as leaders are very actively involved in succession planning, gathering information from outside consultants and institutional or divisional reviews. And then when a faculty member is a leader is appointed, helping support that individual, usually with coaching. Now, when Wesley and I were talking, his involvement with me was actually executing the searches. So we talked about how could we maximize the opportunity to prepare individuals for transitions and then support them after a search committee and a search firm hired that person. And what we realized was that as we plan for transitions, and then when we conduct reviews to gather information, often for the chair and the department, that review was done by a group of outside experts. I've done a number of them. And once that review is completed, we really don't have any interaction thereafter. And although many search committees do use that review, we really don't have any role in providing information to the search committee. And then when people are hired after a successful search, coaching usually has been involved in leadership behaviors. We often provided courses and consultants for our leaders once they're hired, but those individuals haven't really been involved in the review. They may not know about the culture of the organization, and so and they're not specialty specific experts like an individual who might have done the institutional or divisional review. So there was a real disconnect between the information as it's gathered didn't necessarily flow to the benefit of the organization or the candidate. And so I'll let Sarah go back now to talk about how we saw about trying to approach this.
As Dr. Stapleton mentioned, he and Wesley saw a real opportunity to remove the siloed experience and bring continuity to the process, really thinking about what is the opportunity gain from maximizing pediatric insight, knowledge, experience, and expertise, and bringing all of these services under one umbrella and offering the knowledge and insight that comes from the experience that the members of our Child Health Advisory Council have had. And so really, that's what we have had an opportunity to test out with the University of Oklahoma. Dr. Stapleton is going to walk us through how this opportunity presented itself and then the values realized.
So after the many discussions Wesley and I had discussing leadership and coaching and successful transitions, it happened that Wesley had become the talent officer at the University of Oklahoma. And at the same time, Dr. Mo Gessaroon had become the chair of an outstanding department and an excellent children's hospital. And just as it happens, at the time, a number of leadership transitions were occurring. And at the same time, the healthcare system at the University of Oklahoma was undergoing a significant financial rearrangement, which presented additional challenges. And so understanding that there were a lot of challenges all at one time, Dr. Gessaroon and the leadership of the Children's Hospital working with Wesley tried to come up with an innovative approach. And our idea came to the fore. And as a result, the Department of Pediatrics reached out to me and to 5 other former chairs and former deans who were all subspecialists in areas that they were looking for leadership transitions. And our concept was that we would come and do a day-and-a-half review, provide insights that might be helpful to both the candidates, but also to the department and the hospital, understanding what perhaps the best type and qualities and talents of a transition were going to be. And so we came in and then did our reviews. And 3 of us did the first review simultaneously. And that ended up being a terrific opportunity because each of us were doing a different division. Each of those divisions had different circumstances, different resources. And as we, one after the other, presented our reports to the leadership of the hospital and the university and the department, each of us gained insights, and it was a very rich, almost like a department review that helped the department, we hoped, understand who might and what kind of candidate might be the best person for their institution at that time. We've done all 6 reviews. The last one, because the pandemic, was done virtually, which went very well. So we've been able to accomplish this in a number of situations. Then each of us, if we knew candidates, provided those names to the search committee. The first successful transition and search was the name was not provided by our reviewer expert, but because that individual was given the review, contacted the reviewer for some advice and information about the resources, and after the successful search has reached out, and they have a very active engagement. And that was part of the exciting thing for all of us, is that as part of this engagement, we agreed to provide, if desired by the candidate, advisement and coaching following their appointment. And I did the second review that led to a successful search. I did provide that name and 2 others that were all considered by and reviewed by the committee for visits. And that individual was someone I'd worked with, had reached out for information about what the opportunities were, and had intimated to me that because we'd had a professional relationship and having an opportunity to coach after arrival, was very interested and accepted the job. So I think each of the individuals who did reviews found different situations, but it was really gratifying to all of us, the reviewers, because we all had passions for coaching and mentoring, and this was a great opportunity to interact with another department and to interact with young, talented new leaders. And so from our perspective, it was very exciting. Maybe we could see the next slide. This was to be read by Wesley, so I'm going to now channel Wesley because this was what the talent officer at the University of Oklahoma felt were some of the values that were realized. And the idea of being able to sustain the information and culture about a division throughout the consideration of candidates and following the appointment seemed to be attained, and that seemed to be very positive. We hoped, and Wesley felt it was successful, that we helped the department understand what the needs potentially were for achieving the opportunities and success of a candidate. We felt that maybe by having additional information, and Wesley felt it was, that the candidates had a better foundation of understanding when they accepted a position. And that all of us were anxious and enthusiastic about having an opportunity to interact after a person accepted a position, and that seemed to be a very positive thing and is actually being actuated in the people who have accepted the role so far. And then I think, again, it was a great opportunity for us to put our heads together and continue to find a way to operationalize our continued passion after we've stepped down from our primary leadership roles in our own departments. So next slide. So where did this go? Oh, I don't know. Sarah, did you want to ask anything?
Yes, I think Dr. Gesserun was on the line. If he wanted to comment a little bit about the values experience as the chair of pediatrics before Dr. Stapleton talks about where this experience led.
Sure, I'd be happy to. I'm actually very pleased that this started at the University of Oklahoma and the Children's Hospital here. As Bruder was saying, I faced a number of significant challenges. Coming in as a new chair with a large number of leadership vacancies. It in and of itself is a challenge, having that many to do. But also, as a critical care doctor, I certainly may have good knowledge of the national landscape in that field, but not necessarily in all of these other subspecialties. So the opportunity to have nationally recognized leaders in other subspecialties with years of experience as leaders in their field, but also many being department chairs, taking advantage of that expertise to do an effective external objective SWOT analysis of each of my sections, but also really importantly, being able to potentially identify candidates for the positions, because I think what it turns out to be the case is that often the best person to bring on board is not necessarily somebody who is out there looking for a position. So you are able to identify people that may be the right person from their national relationships, and recognizing people who have potentially could fill these roles, and then also having an understanding of what the role looks like because they have been here, have met the folks here, have seen where our strengths and weaknesses are, really helps kind of meld together the best candidate for the position and having the national connections to be able to identify people. It works a lot differently than just a regular search does, and because searches tend to identify people that are looking, and it isn't necessarily someone who's looking who may be the best person for the position. I think the other biggest benefit from my perspective has come from the ability for them to advise me, but also once a search has been successful, the ongoing mentoring and support for the leader that is hired has been tremendously helpful. You know, our first successful recruitment was in neonatology, and that ongoing support, advice, ability to help that person move into a leadership role and be effective has been very much a part of this, and I think very much a part of why I think it's so successful. So I'll turn it back to you all now.
Appreciate it. Thank you for your time.
Yeah, thank you, Mo. Well, this slide tells what happened after we had had our interactions, and we still are having interactions, of course, with the University of Oklahoma. But the leaders uniformly felt that it had been, you know, just a really great experience being involved with leadership development, as I have said. And as we talked about gaining our own skills and coaching and doing reviews, we, in concert with Wesley, were asked to develop a child health advisory council. And the goal of that is to provide the educational offerings and leadership development perspectives, which we are doing through, as a group, through perspective papers and now through webinars, which we're starting today. Our founding council members are myself and Dr. Opipari, who's been introduced. Dr. Arnie Strauss, don't call me Arnold, was chair at Vanderbilt University and pediatrician chief and chair at Cincinnati Children's Hospital. Christine Gleason was a division director and regional director of regional neonatal consortium and also secretary treasurer of the APS. Dr. Craig Hilgemeyer is a gastroenterologist who was a former chair and former dean at Penn State. And Dr. Renee Jenkins, who was chair at Howard University School of Medicine and also president of the American Academy. So we've all been friends for many years, and it's been just a real joy to work together. And if you have questions about what we presented at the end, please feel free to ask me or any of the individuals who've done engagements with the University of Oklahoma. But now I'll turn it over, next slide, to Valerie, who's going to talk about something we're all challenged with at the present time, and that is leadership strategies for challenging financial times. So Valerie, I'll turn it over to you.
Sure, thanks, Bruder. Well, first of all, I want to thank everybody for participating and welcoming you all to our first webinar as part of the CP Insight Leadership and Academic Pediatrics offerings. So we decided for the first webinar, we do a topic that I think is probably front and center in everybody's lives right now, which is dealing with financial challenges, particularly with regards to COVID. And just to put this in perspective, financial challenges are not unique to COVID. And in fact, over the last several decades in academic medicine, we've had a series of really tough periods that have produced some real major financial challenges. So if you go back to the 1980s with the development of the prospective payment system, that was the first point at which health systems were given a fixed payment for services rendered, regardless of what the costs were in order for the services to be rendered. And of course, the prospective payment system launched by CMS ended up giving rise to the DRG groupings that we have learned to love and in many instances hate. During the 1990s was a period when there was a lot of pressure on the clinical revenue and an understanding that to meet the educational missions of the medical schools and the desires to expand medical education and trainees for this country's care delivery, there was a really aggressive expansion of academic medical centers to compete for patients across many specialty continuums and develop what were termed vertically integrated health systems. And again, for those individuals who've led during the 1990s, that expansion and the costs associated with the growth in the academic mission were real financial strains to institutions. And then in 1997, we had the Balanced Budget Act and the rise in Medicaid managed care. Lots and lots of trouble with increased claim denials and delays in being paid for services. There was also the institution of caps to GME slots. And all of this provided significant pressure to the bottom line of academic medical centers, departments of pediatrics, and children's hospitals, in large part because we had this expanded footprint of clinical care where we're getting reduced payments for the services rendered, and we're providing the majority of unreimbursed high expense clinical care to indigent individuals. In 2008 and 2009, we all will remember the economic collapse related to the housing market, but that led to a real serious problem during around 2010 to 2012 with another healthcare financial crisis. And across the country, many medical centers were strapped for resources, and many went through some very significant cost-cutting periods. And then, of course, we're in now the current period of 2020 with COVID-19, which is both a public health and an economic crisis that we're living through in real time. So why is it that academic medical centers in particular are at such strain with regards to financial downturns, particularly those that impact the availability of clinical revenue? And this graph really shows you why. It dates back from FY 1977 to the current period of time. And what you see is the funds flow from external sources to academic medical centers, departments of pediatrics, and hospitals based on key categories. And what you'll notice is that virtually every source of funding coming to us has either been flat or been reduced in nature, including federal research funding, dollar for dollar, year over year. And what we've relied on throughout these decades has been the clinical revenue to support all three of our missions. Next slide. So academic medical centers with a role delivering research and a role delivering medical education and residency training, and relying on increasingly small margins generated from the clinical revenue, are really at risk for a lot of problems. So where were we prior to COVID-19? With that kind of footprint, we were all facing declining incomes and at the same time rising labor costs, making significant challenges to our overall margins. So as an example, in 2012, MedPAC, that studies health system and hospital delivery, identified that the aggregate hospital margins across the United States were actually negative 5.4 in 2012. And during that time, many health systems, including the one that I work at, was developing strategies to try and reduce costs, trying to create new improved operational efficiencies, consolidating supply chain. There were efforts to reduce workforce. There were many, many reiterations at most academic medical centers and children's hospitals around funds flow to reduce expenses. Many of us experienced reduced work RVU payments and a preference to grow service lines that had a high margin. There was also deferred capital at many institutions and streamlined staffing models as just some of the strategies to deal with the financial pressures that were occurring prior to the onset of COVID-19. And in fact, the delivery of care and where the financial windfall was changing quite substantially. So in 2014, the Agency for Healthcare Research and Quality noted that there was a change in the where the margins were actually coming from in the hospitals and in the outpatient setting. And at that time in 2014, elective admissions were responsible for at least 30% of total inpatient revenue. And there was increasingly becoming a rebalancing of where the revenue was coming from the outpatient to the inpatient areas. Next one. And again, just before COVID in 2018, the median US hospital margin was only 2%, which is not very strong. The median hospital days of cash on hand across the country was only 53 days, and accounts receivable were pushing 49 days as a median across the country, with also most significant and a little bit difficult to explain, but as a measure of financial stability, the median asset to liability ratio was not very good when you took everybody in aggregate. And if you focused on just the 25th percentile in the country of the lowest performing hospitals, in that percentile, the median operating margin was negative 4.4, and these hospitals only had an average of 7.6 days of cash on hand. Clearly, a very significantly poor financial position to be going into the COVID pandemic with. Next slide. So COVID is definitely different. It will probably, in hindsight, be the worst financial crisis that we've ever experienced in academic medical centers because of the things that I've already alluded to, that we have an over-reliance on our clinical income to support our academic missions. We're very, very vulnerable to changes in payment models that reduce our clinical income. We have to pay our debt service at the time it's issued. And in 2017, again, as another measure of the financial stability of health systems, it was determined that the highest performing academic medical centers had net assets of $88.3 billion, which sounds quite good, but they also had collectively liabilities of $66.4 billion, not giving a particularly strong margin for them to address a pandemic like COVID-19. So what happened in March 2020 when sadly, we were not all completely understanding what was coming before us? Moody's actually, the major bond credit rating agency, could see what was coming down the line for us. And they looked at the financial outlook for nonprofit, public hospitals, academic medical centers, and they took us from an average stable to a negative Moody's rating, which you all know, or if you don't know, is very, very significant when that is the rating that you go to seek out bond and credit for any of the major institutional things you like to do, such as building new wings to hospitals or building new towers. And why did Moody's make that decision? Because they could predict there would be lowered cash flows. Why? Because we were going to be closing clinics. We were going to be deferring elective surgery. That was a significant proportion of the bottom line margin for a health system. We would be taking on complicated caseloads with increased resources like PPE that are extremely expensive at a time when there weren't even DRGs to cover COVID. In other words, there wasn't a mechanism to submit a bill for a COVID patient where you could be reimbursed a reasonable amount of funding for the care you're providing. It was also in part, this change in rating based on the overall investment portfolios in the country for centers and how much fungible assets were actually available. And as we've all seen, there was a prediction that there would be increased unemployment. And with unemployment, since we very much rely on health benefits provided through employers, a loss of health benefits. And all of this culminated in Moody's saying it was going to be a very bad period for academic medical centers and nonprofit hospitals. Next slide. But with that gloom, there were a couple of perhaps golden pearls. Moody's did predict at the same time that the majority of the hospitals would withstand the impact of COVID-19, especially if they had strong operating cash flows and they had sufficient days of cash on hand. Then we had the first CARES Act, the Coronavirus Aid, Relief, and Economic Security Act, that provided help to academic medical centers and hospitals at large by providing upfront payments to them to weather some of this storm. And just a week ago, the Children's Hospital Association announced that collectively the CHR children's hospitals had received about $1 billion to support their COVID relief efforts. I'm sure if you're like our hospital, it was a good bit of money, but it was nowhere near the amount that was needed to cover the losses that we're seeing. The other good part of the legislation that came out of the doom and gloom of March was that the CMS made a decision to accelerate and advance payments for institutions that provide Medicaid and Medicare services. And how that works is that you were able to apply for funding in the amount that you received in the quarter preceding the onset of COVID-19. And so that gave another significant cash flow into health systems and to hospitals to help them to weather the storm. And I'm sure that might be a topic of conversation, because while it is a transfer of funding, it's not clear what will happen if you do not, in coming out of COVID, actually meet the same level of care provided. But that's another story. At least it was a good cash infusion in a time when it was very much needed. So next slide. So we thought it might be useful to give you one example of many that we could have chosen as to how one might approach a financial downturn. And I'm going to very briefly describe one that occurred in my department at the University of Michigan Medical Center in that 2010-2012 period. And during that time frame, both at the medical school level and at the health system level, we were mandated in 6 months to come up with an across the board 15%, what was called a stress test, but it was a 15% year over year reduction in expenses that had to be, that was mandated to be defined and to be achievable. And so when we were faced with that, and I can tell you that for certain divisions, as you might imagine, if both the medical school side of the house and the hospital side of the house are asking you to do a reduction, a division like a cardiology division or a neonatology division that has a large footprint in the hospital-based delivery of service, high-end care, they were looking at in some parts of their budgets as much as a 30% reduction in order to meet the demands from the medical school and the demands from the health system. So when we were faced with this, we sat down and said, let's just first and foremost develop our principles. What are going to be the principles that drive our strategy to get this year over year list of reductions that we're going to provide to the health system leadership? And we came up with 5, and they were in order of importance. First, we wanted to maintain faculty and staff salaries at competitive levels and ensure we could mount an annual merit program. Second, we wanted to limit the impact of clinical and research productivity. We really wanted to minimize the need for any reductions in force because they're so demoralizing to a community. We wanted to limit the need to utilize our reserves because that's the money that we use to invest in new programs and recruitments and startup packages and so on. And lastly, we wanted to make sure everything that we did would target non-value added activities and those that were really ancillary to our core missions. So with those principles in mind, we came up with a very detailed list of specific strategies and tactics to get to that 15% reduction. And when we presented this to the leadership at the medical center, we said, we know you want us to reduce our expenses, but can it please be on the backs of trying to grow revenue? And we were very lucky at the time. We had enlightened leadership and Jim Wollascroft as our dean and Doug Strong as our CEO. And they said, yes, we will consider giving you an offset if you can truly show us you can grow new revenue, but you must reduce your expenses year over year by 15%. So below our the steps that we took. And as I say, we have a very detailed list of strategies and tactics. And rather than go through all of those specifically, what we're going to do at the end of this webinar is send you a handout that lists by category the specific tactics that we did in 2010 and 2012. And we not only met the goal that we had from the medical center, but we actually exceeded it. And I think the reason we exceeded it is that we took the opportunity for this expense reduction to look really, really critically at how we could grow revenue and how we could get rid of, in particular, non-added value activities while maintaining those core principles that were part of our plan. Next slide. So if you step back and say, since 2010, 2012, maybe even earlier than that, what have hospitals and departments been focusing on? Because really, what we've learned through these periods of real severe financial downturn is that you have to constantly be working on this, because you do not know what's going to be the next pressure on your clinical revenue coming around the corner. And they really come into three major categories of approaches that most systems and hospitals and departments have used. First, strategies to reduce your cost base, getting rid of variability in the care that you provide, limiting certain expensive items that are not based on any evidence. In other words, take the cardiologist that likes a certain catheter, and you have 10 interventional cardiologists and they all want a different catheter. Well, getting rid of that variability is actually an example of how you can really significantly reduce costs. And you can eliminate unnecessary care, ensure your providers are operating within their license so you can get reimbursed for their services, and shifting care to lower cost settings are all sorts of strategies that reduce your cost base. The next major grouping is implementing new care models. And we've been really slow to do this in our industry, but increasingly we have to do this, because it's whether you're an adult provider or a pediatric provider, we are all managing patients with chronic care conditions that utilize tremendously high cost clinical service lines. And so for all of those high chronic care conditions, anything that you can do to better manage them and reduce utilization is a cost saving, because it makes available beds to the institution that can be used for more acute care work. So examples of this include reducing length of stay in high resource areas like the NICU, developing programs that manage medically complex children, and increasingly there's a big drive and a big realization that there have to be ways to better manage mental and physical health conditions that, again, tax the high acuity, expensive inpatient, and quite frankly, even the outpatient clinical delivery. And then the last one is payment models. And this is an area that increasingly, as a leader in an academic medical center or in a department of pediatrics, you really need to be at the table talking about how you can develop reimbursement for payment models that address the chronic care conditions in particular. And I think several of the people, when I saw the list of people on the webinar today, are actually experts in this area. So maybe they might have some comments during the discussion period. So this now is my last slide. When you look at the literature, and when you consider, and there is actually some growing literature already during COVID around how people have been handling the financial downturns and done it successfully, and not only done it successfully, but come out healthier financially than they have before. There are really four concepts that people identify as being critical to their success in coming through a financial downturn. And the first and the most important is the recognition of the culture of your organization. You will not be followed if by your faculty and staff, if they are not feeling like and believe they've been part of a strong supportive culture. And if you're lucky to have that kind of culture in your department or in your academic medical center, where people are always rowing in the same direction, and while they may have periods where they're unhappy with one thing or another, they critically believe in the organization, they believe in the people that they work for, and they're proud to be part of your organization. What people talk about is that each and every one of your financial strategies cannot undermine the culture of your organization, because when you do that, you will inadvertently lose the very thing that provides the cohesiveness that you need to weather a significant financial storm. The second thing that people talk about is your command team. When you're in a financial crisis, it's quite common that the very directors that you've put in place to handle certain mission-focused areas may not actually be the best people to help you develop the strategies. They will be very important in helping you to roll out the strategies, but you may need to expand beyond your core directors, even getting people that are experts in areas that you might not feel very comfortable in, or that expose some of your own vulnerabilities in terms of your understandings. But you need a command team that can help you strategize really effectively the specific tactics that will be successful in allowing you to meet whatever targets you're given by your administrative leadership. Next slide. Communication is the next fundamental factor that people talk about. Nothing undermines culture more than a feeling that you're not transparent, that you're not honest, that you're not giving and planning things with evidence-based guidelines, and that you are consistent in your communications. Every single person in your team, in your department, they may not understand all the nuances of what you're asking them to do, but they have to understand enough to believe in you and to believe that any steps that you're taking are meant to make the organization not only stable, but hopefully stronger when they come through the financial downturn. And then the next area is the thing that you do to make whatever your targets are or whatever your challenges is that's been presented to you, your plan, your principles and strategies that are going to guide how you manage your finances, what you do with your assets, and how you handle your staffing. I provided 5 key bullets that people often talk about. First of all, they talk about the importance of having a phased plan, trying to determine what you need to do in the short term, what the contingencies might be, what you may not want to believe to happen, a worst case scenario, and what would your plan be in each of those successive iterations, your roadmap. How are you going to flex up if some of your strategies don't work in phase 1 and need to be modified in phase 2? People talk about the importance to resist pressure to reduce salaries and reduce benefits. Nothing can be more demoralizing to someone when you're asking them to make difficult changes in their actions or their work for you, and at the same time you give them a personal financial hit. So if you have to reduce FTEs, and sometimes reductions are necessary, they must be rational, people must be able to understand them, and they should be very focused. And along those lines, people talk about the importance of figuring out what those FTE reductions should be, but don't do it multiple times, because all that does, again, is it undermines the cohesiveness of your group and the feeling that, gee, we did one set of cuts and now you promised us no more, and now look, there's another set of cuts coming down the way. Don't lose critical providers or services, and try to resist across the board hiring freezes. It's an easy way to cut money in the short term, but what it will inevitably do is damage your long-term position. So if you have to make FTE cuts, make them appropriately. Try not to do hiring freezes so that you're not in a position that you're not recruiting, because anybody that's been in a position of leading a department or being part of an administrative structure, leading a department or a school, you know you're building with every recruitment for the next decade, and cutting that off for 1 year while your competitors are not doing that, or they're coming and taking your faculty, you'll be in a position that's not very good for you in the long term. And the last thing that people talk about, and probably one of the best articles that I'll refer you to, which will be in another handout that we'll send you, is a story of what happened at the University of Pennsylvania in 1997. And they did all the things that I've listed here, and they resisted strategies that eliminated investment in faculty development, recruitment, and succession planning, because they did not lose sight of the fact that they felt they could come through the financial downturn, and they wanted to come through it not just stable, but they wanted to come through it stronger than they were before. And any of you that have studied or know anything about the University of Pennsylvania will know that they, through the late 90s and into the early 2000s, they became one of the most strongest academic medical centers in this country, and they still are. And the leadership talk about how the decisions they made during that financial downturn was why Penn is where it is today. So at this point, I'm going to stop, and hopefully some of you have got some questions that you'd like to ask, or some comments or perspectives you might share. To get us going, I'm going to turn back to Bruder, because as we were preparing for this webinar, Bruder had some really great examples. And so Bruder, if I could pick on you first to give an example. And then the second person I'd like to pick on is Craig Hillemeyer. I alluded to my great reverence for enlightened leadership at the Dean's Suite and the C-Suite, and maybe Craig could also make some comments following Bruder.
Well, thank you, Valerie. I wish I'd had your wisdom when I started. During my 28 years as a chair, I was reflecting as you were talking on 5 different financial crises I had to go through. And what was interesting is that they were caused by the etiology of the crises. One of them was federal government regulations, another was hospital financial stress, another was 9/11. And another was a practice plan collapse. And then the final one was which I think I'll talk about, was the real estate crash in 2008. Seattle was very heavily hit by the real estate crash. And the stress in that crisis was the fact that the state revenues fell so much because of the economy collapse that we were university faculty and the state froze our salaries. It wasn't that we weren't earning the funds, but we could not provide salary increases or merit increases for 4 years. And that created a huge challenge for me and our administration as a chair, because our key principle and value was making sure that we supported our faculty and that we didn't lose these wonderful people that had chosen and committed to us. And so like you, we communicated in big and little meetings. I visited all the division meetings regularly to give them updates. One of the things we did, unlike a little bit different than your command, was I formed during this time a faculty finance committee that wasn't division chiefs or wasn't vice chairs, but people who, many of them had MBAs, to advise me. And one of the things I did was I asked them to carefully review our central administrative costs so that they knew exactly what we were spending and that we were shepherding their resources in an appropriate way. And then we really tried to look at every possible way that we could support the faculty's salary underpinnings. So we didn't have a hiring freeze. So one of the things we did was, but the key was we had to generate the revenues. We had to have more business so we could hire more people. And when we hired more people, we brought in higher salaries and then went to the university who was willing to say, oh, we have inequity among our salaries. And we were then given the opportunity to increase some of those salaries. And then we really looked hard for those people who deserve promotion, because promotion raises were still okay. And then finally, we looked at philanthropy as a way of increasing discretionary funding, which would offset some of the things that previous people's salaries supported. And so, I can say that within those 4 years, we submitted many retention raises, equity increases, and we continued to hire, but it required, as Valerie said, we had to have the business. in order to do that. And that's really key. We also were on a lean journey to control our costs, but we didn't lose any salary during that time. But every crisis is different. And the key is engaging your faculty, communicating, maintaining your culture and trust, and be strategic. So that's what we did.
So we do have a couple questions from the audience. Craig, I know you were going to comment, and then maybe we'll open it up to questions from the audience.
Yeah, just real quickly, I want to emphasize, I think Valerie and Bruder did a really nice job of getting you some specific strategies, and principles, and tactics to employ. I just wanted to emphasize the importance of really keeping the culture of the organization. It's often a time that a department or a medical school or a health system really defines itself and really defines what their culture is. And so as a leader, and we're all leaders as part of this discussion, we need to try and view this as an opportunity to really define what are those things that define our organization. What are those things that are going to see us through this, because we're going to get through to the other side. And how are we going to get through? That's the most important thing. What are the values that we really think are very important? The transparency that both Bruder and Valerie talked about, as well as getting investment and buy-in from the faculty and staff, setting up groups, having town halls. And as a leader, while ultimately you have to endorse the decisions that come forward and perhaps, create some of those decisions, you have to listen. So don't forget to listen during these times. That's a very crucial thing, is to try and hear what people are saying so that you can take their concerns into account with what you come up with. So that's all I really had to add. Thank you very much, Sarah.
Thank you. I appreciate it. So our first question is around, it says, getting a realistic handle on the obfuscation of funds flow within the academic healthcare center and hospital is challenging. This is particularly the case in a children's hospital within a hospital. Thoughts on learning more?
Yeah, if I could maybe answer, because I was chair of 13 years for a children's hospital, within a larger system. And I think that it's really important to understand the sort of idiosyncrasies as to how you fit into it, because you don't have your own financial footing. And it's really important to try and understand those things that you are accountable for and how best to understand, how the whole system works. One of the things that I would suggest that I would find helpful, especially during the learning phases of my time as a chair, is to find other mentors, other chairs who've been through these cycles, because as Bruder and Valerie pointed out, these cycles happen. These down cycles happen all the time. So find other chairs in the organization and try and get some good thoughts from them on how you might be able to help yourself through that. At least I found that to be very helpful.
So I'll add that that this is one of the most complicated questions, but it's also fundamentally incredible. So funds flow at every academic medical center I've ever been to, they're all different. There is no one funds flow model that's the same at any one institution. And the most enlightened institutions and leadership of those institutions are institutions that understand people need to understand the funds flow in order for them to be motivated to do the kinds of things that you want to do. So whereas in the last decade, people were very, very reticent to tell you about the funds flow, it was meant to be a secret and not meant for you to know where money flows and goes. There's a new enlightenment at many academic medical centers that's saying, no. If we need to get you to move in a direction that's good for the organization, you have to understand the funds flow. So one thing that I've told people to do, and Desmond, I don't know where you're from, but I will tell you that I tell people to go and sit with those leaders that control funds flow in the medical school, in the hospital health system, in the children's hospital, the CEO of the main health system, finance guy. Most of them would love to meet you and they like to talk. And if you can get them to have an open-ended conversation on helping you to understand at the level that you need how your funds flows work, hopefully they'll be willing to spend the time to tell you a little bit more about it. But understanding the funds flow is key. And this is a responsibility increasingly that departments of pediatrics chairs and their administrative leaders really have to have. And your faculty are demanding to know some of it too. So it's kind of goes throughout the department.
Great. Thank you, Valerie. We do have another question from Dr. Brophy around, it says, so many academic health centers have cut benefits during the COVID pandemic. One of your points about resisting cutting benefits when possible. This became an early approach by many centers. Any advice on how to approach returning those benefits and what approach you may take on that? Thanks much.
So I'll give you an example from 2010, 2012. We had a system in our department whereby we paid out to faculty funds based on them more than covering their research effort, their space costs of their laboratory programs. And we during this downturn, we decided, especially when we looked at the amount of money people had sitting in accounts, we said, that would be a good source of funds to hold in escrow if people don't need the money, with the understanding that when we come through this financial downturn, everything that we held in escrow to help with our bottom line would be given back to them. And the faculty understood that. They understood that we weren't taking the money from them. We were going to hold it, and instead of paying it out to sit in an account that they didn't need to utilize, that was a way for them to contribute to helping us in the short term to meet this expense reduction. Because once it goes out into your accounts, it's essentially seen as something that we've spent. So that would be an example at the department level. Pat, if your question is getting to what do you do when they cut your retirement benefits, that's a much harder question to answer because that's usually done at a systems level. But again, it would be my hope that any institution that has to go to such dire, situations where they're cutting benefits to faculty and staff, that when they come out of the downturn, that they'd recognize that and do something that would offset that very real financial hit to their employees. If you cut your retirement benefits in a young investigator in 2020, that has impact on them for the next 3 to 4 decades. That's real loss of money. And so one would hope that, again, during a financial recovery, that people would recognize that hurt and make it at least partially offset.
I think Valerie gave a really good response. I would just make sure that if you do have to cut those benefits for a short period of time, that people know when that decision is going to be reconsidered, because that, stress is a function of duration and intensity. And if the duration is open-ended, it's a much more difficult stress than if it's like in 6 months, we're going to be looking at this again, or a year, we're going to be looking at this again.
So this is Pat speaking. So I appreciate this. This is some great discussion. One of the questions I had, and you're right, Valerie, at an institutional level, university level, if you have an integrated system, you're at the behest of higher powers, as I would say. But when you are advocating to the leadership, to the dean, whoever, how do you approach this in a logical way? Because obviously the longer these things go on, the more impact it has on your, as you say, duration and stress. And so how do you, or any tips that you would have to push the agenda to get benefits restored in a short period of time? And if you have any thoughts about that, could you share some techniques?
Well, I think one of the reasons, the panel wanted to do this topic is that we're living through this horrendous financial situation in real time. And we are well aware of many, many institutional decisions that go against the literature. So what we wanted to provide you with is some real information that you could utilize in having the conversations when you as a department chair are sitting around the table And people are saying, what are we going to do with this COVID, 300 million or 400 million downturn? And if you're not knowledgeable and you don't know the literature and you don't know examples of institutions that have faced similar situations and have made very different decisions than we are discussing right now, and came through that period stronger because of their decisions. So I know of an institution that cut their benefits, and the leader of the COVID unit quit and left. He was demoralized by the fact that he had taken the institution successfully through a COVID pandemic and led what was arguably one of the most difficult, converting all these general beds to ICU beds and being responsible for this massive undertaking. And then to wake up the next day and say, well, thank you kindly, but you no longer have your retirement benefits. We're freezing your salary and we're cutting, half a dozen of your staff. I can tell you it didn't go over well, and it doesn't go over well. And what ends up happening is you take a big hit to the morale of your organization when you lose a leader like that has demonstrated complete commitment to the situation and the organization. So part of the reason, Pat, of doing this is to really help everybody to understand that there is literature out there about institutions and how they've handled these things, and how they've handled it with specific, principles and strategies that are meant to protect as much as you can your community.
One add-on I might give is that a leader of the department or whatever unit you're a leader of, it's important for you to let leadership know and have very frequent communication with them if you think people are at risk for leaving and or if they leave, because that sometimes is impactful in helping them understand how serious the decisions that they've made are, and makes it so that they're going to be more responsive to you. Not in a histrionic way, but just saying, look, we're going to leave this person. The impact on morale is going to be this. It's going to cost this much to recruit them when we get out of this. You need to make sure they're aware of those things.
Excellent. Oh, that's great. If you, I don't know if you guys can share, but if you have a good reading list, that would be awesome if you would share it with us all. So terrific discussion. Thanks. Appreciate it very much.
Yes, Dr. Opipari has put together a list of articles, and that will be coming out as well as the references that she mentioned in her talk.
Excellent.
I'll be emailing those out to everyone. Yes. Well, thank you all so much for taking the time today. I know we are just a couple minutes over. Just want to thank you all for joining us for our first CP Insight. Stay tuned as we plan to host these quarterly, looking towards our next program at the end of January. So thank you all. If you have additional feedback, feel free to email me at Sarah@CareerPhysician or stick it into the chat while you're still here today. Thank you.